Hi, my name is Matthew Tenser. Thank you for watching our presentation today. I'll be speaking on intracranial atherosclerotic disease. I'm an interventional neurologist and a vascular neurologist here at USC, and I'll present on intracranial stenosis today. So as far as a brief introduction, there's about 800,000 strokes a year in the US, about 10% of which are due to intracranial narrowing or atherosclerosis. As you can see on the picture here, with the arrow, there's a obvious narrowing or even almost occlusion on that blood vessel. Intracranial stenosis is relatively common. We find it to be in about 3 to 13% of patients. The risk of stroke is pretty variable depending on how tight it is, where it is, and what the other blood vessel connections are up in the brain. But the risk of stroke has been estimated to be anywhere from 7 to 40% over 1 year, with a recurrent risk of stroke after that first one of up to 50%. It's more common in certain populations, such as Asians or African Americans. And for example, in China is responsible for almost 50% of strokes in their patients. How does it cause a stroke? Well, there's several different ways. Number one, where the narrowing actually is, a clot can form due to irregular blood flow. There are certain things that can make it more likely to form a clot, such as rupture of a plaque, or ulceration of a plaque, or hematoma inside the atherosclerotic plaque at the site of the narrowing. You can get a clot forming from the stenosis and then migrating distally to cause a distal stroke. And then also the stenosis can be so severe that the blood flow is actually reduced and impaired to the distal brain tissue, causing a stroke due to lack of blood flow due to the narrowing itself. As we talked about, there's a risk of stroke, and it can be pretty variable depending on where it is and how narrow it is. If it is found without a stroke, meaning it's asymptomatic, the risk of stroke is thought to be relatively low, from 0 to 3.5%. Once it actually causes a stroke, the risk once we say it's actually symptomatic, the risk of stroke is relatively high and can be up to 30 to 40%. And as you can see on some of these numbers here, depending on the vessel, it can be anywhere from 19 to 34%. Risk of stroke, depending on how narrow it is and what the intracranial collateral circulation is for that particular patient. One question we get is, does it change if we treat it aggressively? Does it get better? Does it get worse? What happens with these lesions? And there we have several studies here suggesting that they actually are a dynamic process. One study showed that when you use aspirin and cilostazol, which are antithrombotic medications, there was a lower risk of progression in the aspirin cilostazol group versus the aspirin alone group. Another study showed with observation that about 20% of patients the narrowing improved with aggressive medical management. Of about 40% progressed and about 40% remained unchanged. So the vast majority of patients with intracranial stenosis either remain the same or progress despite aggressive medical therapy, which can then increase your risk of stroke in the future. This is based on some early studies. These are some of the earlier studies back several years ago. And you can see here that most of them have pretty severe stenosis, anywhere from 63 to 82%. And the recurrent stroke rate can be anywhere up to 14 or 15%. So again, a high-risk lesion in these patients for causing future stroke. What this led to was a large randomized trial called SAMPRIS, and this came out several years ago. And this was testing stenting for intracranial stenting, angioplasty and stenting for these lesions versus aggressive medical management, and which one was better at preventing strokes in the future. And they had to have a high degree of stenosis, anywhere from 70 to 99%. And again, it was aggressive medical management, which is aspirin, Plavix, statin, plus or minus intracranial stenting. And what they found was that the stroke rate was actually much higher than expected for the stenting group. They estimated it to be approximately 10 to 13%, and based on prior studies, and they found it was actually closer to 15%. And the stroke rate for the medical management group was actually much lower than expected, about 6% versus what they expected from prior studies to be about 20%. And so the study was stopped early, and it was determined that for intracranial stenosis, aggressive medical management was preferable to intracranial angioplasty and stenting for preventing strokes in this patient population. Looking further, looking a little bit closer into the study itself, it was determined that a lot of the strokes in the stented group were not necessarily from the revascularization or improvement of the stenosis itself. It was from the procedure. They found that a lot of strokes were due to what were called perforator occlusions, and you can see on the diagram on the page here, perforators are small branches arising from the main trunk of a vessel. So if there was a narrowing in that yellow circle, you can imagine if there's a balloon inflated and a stent placed, some of those little branches off to the side could be blocked by the stent itself. So it wasn't a stroke from the stent opening up the artery in a distal territory. It was direct blockage of these small perforating branches by the device itself. Some of the strokes were also perforations or ruptures during the procedure, meaning a wire or another part of the device caused a hole in the artery, causing bleeding up in the brain. And again, it's not necessarily due to, the stroke was not due to the stent itself. It was due to a procedural complication. So hard to attribute that to the stent itself in stroke, in causing the strokes. So what do we learn though from this study? Even though it was not perfectly designed, we realized just how good medical management is these days, how effective aspirin, Plavix, statin, diabetes control, tobacco control, how effective that is in preventing strokes in the future. It also demonstrated the importance of periprocedural and intraprocedural factors in these patient populations. We found that we need to be more aggressive with our antiplatelet testing to see if patients respond to Plavix, how well their statin reduces their cholesterol. We realized how important blood pressure control is in these patients, and how important it is to watch and observe the stents to make sure they stay open and little emboli are not forming and going distal and causing strokes. This led to a new indication for intracranial angioplasty and stenting in patients with intracranial stenosis. The most important of which is circled here, and what the FDA determines as appropriate use for these devices is a patient has to have 2 strokes despite medical therapy, then they qualify for intracranial angioplasty and stenting. Otherwise, they need to have severe stenosis, 70 to 99%. It needs to be done approximately 1 week after the event for this to be an indicated procedure for intracranial stenosis. Now, there are some more recent data now. This is a study called WEAVE, and is a registry of angioplasty and stenting for intracranial stenosis for patients that meet the new FDA criteria. They also looked at these other factors that I mentioned, the periprocedural and intraprocedural care. How well does a patient respond to Plavix? How long have they been on their medications? When was their stroke? Was it more than 7 days ago? So these patients in this registry met all of the current FDA criteria. And here's the study. So again, they needed to have severe stenosis. They were greater than 1 week from their event. They tested antiplatelets when possible. And what they found was that the stroke rate in this patient population, when they met the new FDA criteria, was extremely low, approximately 2.5%. Now again, comparing it to the Sampras, it was 15%. When the patients were treated with the new labeling from the FDA, the stroke rate was very low, approximately 2.6%. The WEAVE patients were then followed out to 1 year and observed again for their long-term stroke rate. And what they found, as you can see in the upper left, Sampras is on top. The stroke rate was 20%. The Sampras aggressive medical management group was 12%. And in the woven, it was down to 8%. And again, compared to Sampras on the right slide there, you can see that the long-term 1 to 12-month stroke rate was much lower in the weave and woven patient population compared to Sampras. And again, what this suggests is that when the patients are selected carefully and they are treated appropriately with their medical management and they are followed and we are sure that they are responding to the antithrombotic medications, we're following their blood pressure closely in the ICU, the stroke rate from angioplasty and stenting for severe symptomatic intracranial stenosis is actually very, very low. So what are the current recommendations? What we found is this is from the most up-to-date American Heart Association guidelines. And to summarize this slide, it's basically aggressive medical management first, aspirin, Plavix, blood pressure control, cholesterol control, stopping smoking. These are all the first-line recommendations for preventing strokes with patients with intracranial stenosis. we found the aggressive medical management has been determined to be aspirin and Plavix, not some of the other medications, as we don't have enough data with other medications like Silastazol or some of the newer 2B3 inhibitors. It's aggressive blood pressure control with systolic pressures less than 140. When patients fail these medical therapies and have strokes despite these aggressive medical therapies, that's when we start to talk about intracranial angioplasty and stenting or revascularization of the intracranial circulation. So in summary, for these patients, again, first line is aggressive medical management: aspirin, Plavix, statin, tobacco control, diabetes control. And if somebody should have a stroke despite this aggressive medical management and they have severe stenosis of 70 to 99%, this is when we start talking about intracranial angioplasty and stenting for these patients for stroke prevention. This is the guidelines from the current neurointerventional societies. Again, it's aspirin and clopidogrel for 3 months, then aspirin or Plavix alone. And if they fail those medications, we will then consider angioplasty and stenting. They specify that we typically do not use the coronary balloons, and I'll show an example of that in a minute. This is for the intracranial stenosis system of the Wingspan and Gateway devices. So when do we stent? As I said, they need to have a severe stenosis, greater than 70%. It needs to be symptomatic, meaning it's caused a stroke. The symptoms have to be in the territory referable to that vessel. They need to have failed maximal medical therapy, and again, that's considered to be aspirin, Plavix, statin, and aggressive lifestyle risk factor modification. And again, it should be done by experienced physicians. The Weave and Woven data demonstrated that when the stents were placed by physicians that have done many of these procedures, the stroke rate was very low, almost zero, and the complications occurred typically in those that were less experienced. So again, you want somebody that's done a fair number of these procedures doing this on the patient population. So some case examples. This is the room that we use. As you can see here, the machine has an anterior and a lateral X-ray system, and it gives us an AP and a lateral picture of the blood vessels, as you can see on the side of your screen. We can access the vessels either in the femoral artery, the radial artery, the brachial artery, or even directly puncture the carotid artery, with the goal of eventually getting our devices up into the head, as you can see here. We use different shaped catheters to allow for variance in the anatomy, but one way or another, we try to get our devices up into the vessels up in the brain. This is a typical system, and as you can see, it's minimally invasive with just a puncture in the femoral artery in this particular patient. You can see the sheath in the femoral artery with a catheter on a heparinized flush to prevent clots from forming in the devices themselves. And then you can barely see the microcatheter, the third device there, which is what we use to go up into the brain itself. And these catheters are less than the size of angel hair spaghetti, and the wires that we use to get up there are about 14/1000ths of an inch. So a very small system, minimally invasive, and this is how we get our devices up into the brain to treat these patients. This is the difference between a neuroballoon and a coronary balloon. On the bottom, you can see a typical coronary balloon, which is a stent mounted on a balloon in a catheter itself. So everything is one single system. The benefit is there's not a lot of moving parts and a lot of exchanging devices out. The downside is these devices are relatively stiff because the balloon and the stent are all on one catheter. It's harder to navigate these devices because everything is on one catheter. It makes them a little stiff and tough to get through very tortuous or twisted vessels. The neuro system is above, and you can see that it's a separate balloon and stent. And so it makes the device a little bit more navigable and softer and easier to take these tight turns that we have up in the brain. This is a patient that came in that had an event approximately 1 month prior, and he was now on aspirin, Plavix, and statin, and he came in with new symptoms in the right side of the brain. You can see the stroke there in the right MC territory. This is his MRA, and you can see in the circled area there is a short segment of severe stenosis. So at this point he has failed medical therapy. This is his second event, and so we took him for revascularization with angioplasty and stenting. You can see the angiogram and just how tight the narrowing is. This picture shows a small wire that we navigate through the vessel. You can barely see the wire because it is so small. Here's the balloon that's inflated, and you can see the small shadow there. The balloon is about 2 millimeters. And then once the stent is in place, now you can see that the stenosis is much improved and the blood flow is much improved, and he ended up doing very well without any further strokes. Another patient who was admitted with imbalance and vertigo. His MRI showed a cerebellar stroke. He was started on aggressive medical therapy. He was getting ready to go to rehab after some physical therapy in the hospital and had new symptoms. And now on the MRI, you can see the new strokes on the left side of the cerebellum. So now he's had strokes on both sides of the cerebellum in the posterior circulation despite aggressive medical therapy. The MRA demonstrated that his one vertebral artery was completely occluded as it entered the skull. The other vertebral artery had a high-grade stenosis, and he had no collateral circulation from the anterior circulation as he had no posterior communicating artery. So he had an isolated posterior circulation with a severe stenosis in the one blood vessel that was feeding the posterior part of his brain. So here's an angiogram, and you can see in the circled area this high degree of stenosis in the vertebral artery. And again, this is the only blood vessel feeding the brainstem and the posterior circulation. So again, here he is with the wire through the stenosis, and then the balloon is inflated to improve the stenosis and break up the plaque. And here it is with the stent in place, and now you can see the stenosis is resolved without any residual narrowing, and he had no further strokes after this procedure. Another typical patient, a 69-year-old person with right MCA symptoms, and you can see the high degree of stenosis in that right middle cerebral artery. When they first came in, they were already on aspirin, Plavix, and statin, and aggressive medical therapy of all their vascular risk factors. Despite this, they had another stroke, and so we felt this was an appropriate patient to treat with angioplasty and stenting. Here it is with the wire across, and again, you can barely see the wire because of the size. And here it is once the stent is in place without any residual stenosis. And again, the procedure went well, and the patient had no further strokes after this procedure. Another patient, this time with left MCA symptoms, and you can see the severe stenosis at the origin of the left middle cerebral artery with the balloon in place, and then with the stent in place, and no residual stenosis. And again, the patient did well without any further strokes. Sometimes we have to place these stents acutely. Most of these patients, these stents are placed 1 week after the event in order to prevent another stroke. This patient came in with right MCA symptoms. We took him for a thrombectomy. You can see the CAT scan there and the CAT scan angiogram without any large stroke. But on the CAT scan angiogram, you can see an occlusion of the right middle cerebral artery. When we took him to the angiogram, we saw that the right middle cerebral artery was occluded at its origin. What some of these other pictures demonstrate is that the right MCA territory is filling late from collateral circulation. Sometimes this can be a sign of an intracranial stenosis, as these collaterals can take time to develop. So if this is an acute occlusion, sometimes these collaterals have not had a chance to develop. If somebody has a stenosis that's been there for a while, these vessels have developed and there's good collateral circulation to the territory. So this was suggestive of an underlying intracranial stenosis. We went in with our thrombectomy devices, and we were able to open up the vessel with the stent retriever. However, every time we watched it, it would then eventually shut down, again consistent with an underlying stenosis. We then, and here's an example, here it is after the device is deployed. We watched it for a few minutes, and you can see it start to re-occlude, and again, it eventually progresses to complete re-occlusion. We tried angioplasty as well. We put a small balloon there, inflated the balloon to try to open up the vessel. Every time we did that, though, and again, the vessel re-occluded. So we decided that we needed to place a stent to maintain this the vessel patency. In this case, we had to use a coronary balloon because we did not have the appropriately sized Wingspan device at this time. And again, you can see the wire deployed over the area of stenosis. We then were able to navigate the stent, the balloon-mounted stent in the area of stenosis. And here it is after deployment of the balloon. And you can see no residual narrowing in the area of the right middle cerebral artery. Here's his MRI the next day with minimal stroke on the right, and he went home 2 days later completely intact and has remained stable as an outpatient. Sometimes we can get intracranial stenosis not from atherosclerosis, but from something called a dissection. And you can see on the picture here, a dissection is an injury to the wall of the artery. The inner lining of the artery peels away and eventually can eventually become so severe that the lumen of the vessel is actually compromised, like an intracranial stenosis. This is a case of a young patient who was at the gym, was exerting himself, and then came home with headache, neck pain, and diaphoresis. Went to an outside hospital, and when somebody complains of neck pain and sweating and diaphoresis, the first thing they worry about is meningitis. He had a lumbar puncture, which did not demonstrate meningitis, and then eventually had progression of his neurologic symptoms consistent with a basilar artery occlusion. They did a CT angiogram, which demonstrated vertebral artery dissections as well as a basilar artery occlusion. So he was transferred to our facility for intervention. So here's the first angiogram, and you can see the dissection in the vertebral artery on the right. This is outside the brain. But you can see from both vertebral artery angiograms in the middle and on the side that there's no intracranial flow to the basilar artery. And so now you can see that the basilar artery has now been completely revascularized, and there's now good flow in the posterior circulation. As we pulled our catheter out, we could see that there is a severe dissection of this vertebral artery, and you can see the narrowing here on these pictures with the lack of flow up into the basilar artery. So what we decided is we had to put a stent in this vessel as well to treat this narrowing. We use this pipeline, what's called a pipeline device, which is a flow diverting device designed for the intracranial vessels and very navigable and very good at taking these tight turns. And you can see here after deployment of the device, there is complete revascularization of the intracranial circulation without any residual narrowing, and this patient ended up doing very well. Finally, we have one more dissection. This is a young woman who was in a motor vehicle accident. And you can see here that she had a severe dissection and aneurysm due to the dissection from her trauma. Initially, she had multiple fractures, required chest tubes, had a skull fracture, and was stabilized in the ICU for 2 weeks. Once she was more stable, we felt it was safe to address this dissection and stenosis and aneurysm. And so we started her on blood thinning medications and took her to the cath lab and in an attempt to fix this stenosis and dissection. We placed the flow diverting stent across the area of stenosis and dissection to remodel the vessel and improve the flow and caliber of the vessel. This is the angiogram immediately after the device was placed. Now you can see that the vessel has been completely remodeled without any residual narrowing or stenosis from the dissection. And then 6 months later, now you can see that the stenosis and dissection are completely resolved, and she ended up doing very well. And so in summary, again, for intracranial stenosis, this is a common cause of stroke. But what we know now is that based on data, we need to do aggressive medical management first. Aspirin, Plavix, statin, lifestyle modifications. And should somebody develop a new stroke after the implementation of these medications, then we will consider intracranial angioplasty and stenting. Thank you very much for listening to this video. I'd like to thank Dr. Zada and the rest of the Department of Neurosurgery for the opportunity to present this to you. Thank you.